So it's actually an absolute pleasure to give this talk, evidence-based management of intracerebral hemorrhage, an update. And I'm thankful for Professor Vasev for giving me the opportunity and inviting me to this lecture. So I want to talk about three things when it comes down to intracerebral hemorrhage. I want to talk about the pathophysiology. I want to talk about the treatment, and then how do we translate that into effective treatment that improves the outcomes of patients with intracerebral hemorrhage. So let's talk about the pathophysiology of intracerebral hemorrhage and its implications for treatment. So I think one thing that we have learned over the last 3 decades is that intracerebral hemorrhage is not a monophasic event, but actually a progressive event. And in fact, there is progression of disease all the way through the first week. In the first few hours after intracerebral hemorrhage, as you can see on the slides, there is an expansion of the hematoma. So because patients are coming in earlier, we are actually doing more serial CT scans. We have recognized that intracerebral hemorrhage is actually progressive. So there is actually hematoma expansion in the first few hours after occurrence of the primary hemorrhage. And after the first few hours, we don't really see much of expansion, but we actually do see what we call as expansion of edema. So this is a region around the hematoma which actually appears as a hypodensity, and there is actually progression of that edema and mass effect that can go all the way up to 1 week. So one of the things that almost 3 decades ago we recognized is when patients come to the hospital, many of them actually have neurological deterioration. So they may have actually come in awake and talking, and within the next few hours, they actually are comatose, requiring emergent resuscitation, mechanical ventilation, and aggressive treatment for intracranial pressure. And multiple studies have shown that hematoma expansion is the major reason for neurological deterioration in patients with intracerebral hemorrhage. And here's actually a slide that you can see that how the hematoma starts at baseline, and within 6 hours, you can see there's substantial expansion, both in the parenchymal component, and there is new blood into the ventricular system, and obviously with an increased mass effect in the same individual. And it seemed like hematoma expansion is something that occurs very early on. So most of the expansion would occur in the first 3 hours after symptom onset. Some additional patients will have expansion all the way up to 12 hours, but it's very rare to actually have hematoma expansion after the first 24 hours of symptom onset. And then obviously there is what is happening in the region of the brain that's next to the hematoma. So as you can see that there is a green color attributed to the hypodensity that surrounds the hematoma. And the region that surrounds the hematoma is also undergoing several changes. There are metabolic changes, there are cerebral blood flow changes in that particular region. And actually you can see that region actually tends to expand all the way up to 1 week after the occurrence of the initial hemorrhage. So for many years, people believed that there was ischemia around the hematoma. So the hematoma, by compression of surrounding microvessels, created a zone of ischemia around itself. But more recent studies have actually shown that it's more like what we would call as a hibernation stage. So there is actually a decrease in blood flow around the hematoma, but actually there's also a decrease in metabolism around the hematoma. So the decrease in blood flow is quite adequate for the hypometabolic tissue that surrounds the hematoma. And in fact, what we know now is the metabolic failure and metabolic suppression is the primary event, and cerebral blood flow reduction is a secondary event. And between 2 and 14, there is patchy recovery of both cerebral blood flow and metabolism, but takes around 14 days before all of the cerebral blood flow and metabolic changes normalize around the hematoma. And this understanding was only made possible once we actually got positron emission tomography that allowed us to look at not just cerebral blood flow, but cerebral metabolism around the hematoma. So here is actually the region around the brain that is being studied using position emission tomography. And you can actually see the region, if you look at cerebral blood flow, you can see there is decrease in cerebral blood flow around the hematoma. But you actually look at cerebral metabolism, there's also concurrent reduction in cerebral metabolism. So if you look at oxygen extraction fraction, which actually is an indicator of ischemia, so every time a tissue is ischemic, the oxygen extraction fraction actually increases. And you can notice that there is no change in oxygen extraction fraction. So essentially the blood flow is quite adequate to supply the hypometabolic tissues. So I think that now we know that perihematoma ischemia, which we had believed for a long time never existed, and metabolic failure is the primary event around the hematoma. More recent evidence is suggesting that the neural injury that we thought was very focal, so it was around the hematoma, is perhaps not so, and the injury may be more global. I think in experimental and clinical studies, there has been expression of inflammatory markers, alternation of blood flow, and blood-brain barrier breakdown in regions distant and contralateral to the hematoma. So it's not just the region around the hematoma that's affected, but it seems like it's more of a global disease. There is more changes in the regions of the brain that are not even adjacent to the hematoma. And essentially, we had actually looked at that question in one of the studies that we had done, the antihypertensive treatment of acute cerebral hemorrhage, or the ATACH I study, where we actually measured the volume of the brain in total. So not the area of the brain around the hematoma, but the volume of the brain in total. And there seems to be an increase in the brain volume in the first 24 hours, and actually even later on. So obviously, it is suggesting that the brain is getting swollen in areas not just adjacent to the hematoma, but distant to the hematoma. And here is actually, you can see the methodology to look at total cerebral blood volume. Essentially, the volume of the brain that's not the hematoma, that's not the perihematoma edema, is what is measured. And if you measure the volume of the brain in total, you can see that there is an increase in the volume of the brain at 24 hours and even additional increase in the 48 hours. So there is this global cerebral edema and perhaps global cerebral edema injury that can happen with intracerebral hemorrhage, and moving our understanding from a focal disease to perhaps a more global disease. So let's just take this pathophysiology and turn it into treatment. How do we actually take this pathophysiology and turn it into a treatment paradigm? So in terms of treatment, if you look at the pathophysiology, as you can tell in this particular slide, essentially in the initial part, the focus is to treat hematoma or prevent hematoma expansion. And then subsequently, the focus is to treat mass spec, which is both because of the hematoma and also because of the perihematoma edema and perhaps even global cerebral edema. So what can we do to prevent hematoma expansion? And I think one thing that has been studied in the last 20 years is aggressive reduction of blood pressure. And there were two major trials that were done in the last 20 years. One was the antihypertensive treatment of cerebral hemorrhage, ATACH I and ATACH II, and obviously there was the INTERACT I and II. And the concept of both trials are very similar. Basically, actually looking at patients who come in early on with intracerebral hemorrhage, and either treating them with standard blood pressure reduction, which was to keep the systolic blood pressure less than 180 millimeter of mercury, or intensive systolic blood pressure reduction, which was to keep the systolic blood pressure less than 140 millimeter of mercury. And the theory behind it was that essentially the patients who get aggressive blood pressure reduction and intensive systolic blood pressure reduction would have lower rates of hematoma expansion and subsequently have better outcomes, better functional outcomes at 3 months. So the INTERACT II completed first, and essentially it randomized patients to two groups. Again, the first group, 1,430 patients being randomized to keep the systolic blood pressure less than 180 millimeter of mercury. And then the intensive treatment group, goal was to keep it less than 140 millimeter of mercury. A variety of antihypertensive agents were used. And what you can actually tell is that the group that was supposed to be intensive treatment group or intensive systolic blood pressure reduction, the goals were barely met. So the blood pressure was not really below 140 millimeter of mercury. It was more like around 140 millimeter of mercury systolic. And the hematoma expansion, surprisingly, was not different. So you can actually see that the rate of hematoma expansion is very similar in the group that got intensive treatment or compared to standard systolic blood pressure reduction. But actually, if you look at the 3-month outcome, so again, looking at the rate of death and disability, there was actually somewhat of a reduction. It was not significant, but there was a trend that 51% of the patients who got intensive blood pressure reduction had death and disability, which was lower than the 55% rate in the patient that got standard systolic blood pressure reduction. So perhaps some evidence that intensive systolic blood pressure reduction may have the potential to improve the outcome of patients with intensive intracerebral hemorrhage. And obviously, the ATACH trial was actually using an intravenous agent, intravenous nicardipine, in all the patients. And therefore, in the phase 1 study or the phase 2 study, blood pressure reduction was more aggressive, more consistent, and perhaps the hematoma enlargement was actually lower, around 19%. So there was great enthusiasm that the ATACH II will actually show the benefit of intensive systolic blood pressure reduction, that actually a trend was observed in the INTERACT II. But in the interim, after the publication of ATACH or INTERACT II, the American Heart Association Stroke Council guidelines actually started recommending patients who have a systolic blood pressure between 150 and 200 millimeter of mercury. Lowering blood pressure to 140 millimeter of mercury is safe and may be effective for improving functional outcomes. So they're not saying lowering it below 140 millimeter of mercury, they're saying lowering it to 140 millimeter of mercury, so approximately bring it to around 140 millimeter of mercury systolic blood pressure. And patients with systolic blood pressure more than 220 millimeter of mercury, it may be reasonable for aggressive blood pressure reduction using continuous infusion and frequent blood pressure monitoring. So now the ATACH II trial got completed, and as the ATACH II trial was geared toward more aggressive blood pressure reduction, you can actually see the intensive treatment group. The blood pressure reduction was actually more around 110 to 120 millimeters systolic. The goal was to keep it less than 140 millimeter mercury, and you can see the blood pressure is rapidly reduced and maintained below 140 millimeter of mercury. On the other hand, for intensive or the standard treatment group, the blood pressure also got reduced very effectively. But it perhaps got reduced more effectively than we wanted it to be. So it was actually starting to approach closer to 150 millimeter of mercury, rather than our initial goal to keep it somewhere between 160 and 170 millimeter of mercury systolic blood pressure. So the term may be the same between ATACH II and INTERACT II, intensive and standard treatment, but it perhaps has different meanings between the two trials. The standard treatment group in the ATACH II perhaps resembles more of the INTERACT II intensive treatment group. So I think that when we use the word standard and intensive systolic blood pressure reduction, we have to be a little cautious that each trial, this term implied something different in terms of systolic blood pressure profile. So if you look at hematoma expansion, there was actually a trend that patients who got intensive systolic blood pressure reduction, a very effective reduction in systolic blood pressure, the expansion rate was 18.9% as compared to 24.4% in the standard treatment group. So there was a trend that hematoma expansion could actually be lowered with more effective, more aggressive and intensive systolic blood pressure reduction. Obviously, the next question is, did it improve the outcome of patients with intracerebral hemorrhage? And surprisingly, despite the fact that hematoma expansion was lower, if you look at the outcome, so again, we are measuring outcome as death and disability using a modified Rankin scale 4 to 6. which means that either the patient has severe disability, bedridden, or actually has died. 38.7% in the intensive treatment group and 37.7% in the standard treatment group had death or disability. Absolutely no significant difference between the two groups. In fact, they look like a mirror image of each other. So the outcome of the patients who were treated with intensive systolic blood pressure reduction was no different than those who were treated with standard systolic blood pressure reduction. So we had postulated a more rapid intensive systolic blood pressure reduction and exclusion of patients who have no requirement for antihypertensive medication would it more likely to demonstrate a larger magnitude of therapeutic benefit. But our results did not confirm this hypothesis. One of the interesting things we learned is that perhaps there is a detrimental effect of intensive systolic blood pressure reduction, but not so much as on the brain, but actually on the kidneys, because patients who have chronic hypertension and intracerebral hemorrhage do have chronic hypertensive renal disease. And essentially, if you look at renal adverse events, it was more than two-folds higher chance of having renal complications or adverse events with intensive systolic blood pressure reduction as compared to standard systolic blood pressure reduction. So there is actually a consequence of intensive systolic blood pressure reduction, more so on the kidneys than the brain, something that was not expected before when we were learning more about blood pressure reduction in patients with intracerebral hemorrhage. So what does that mean today? I think that today, anybody who comes with intracerebral hemorrhage has a systolic blood pressure of more than 180 millimeter mercury, perhaps should be treated. So I think the treatment threshold is perhaps a systolic blood pressure of 180 millimeter mercury. You can actually use even a lower threshold like 150 millimeter mercury based on the INTERACT II trial, but you have to understand a lot of people in the end may not even need intravenous medication and the blood pressure may spontaneously resolve. What is the time window for initiation? I think less than 4.5 hours of symptom onset, but it seemed like anybody who comes in within 24 hours of symptom onset would actually be started on intravenous medication, but really the benefit is early on because hematoma expansion actually occurs very early on. What is the treatment goal? I think that we perhaps keeping it less than 140 millimeter of mercury is too aggressive. There are consequences to the kidney and perhaps no additional benefit. So perhaps just keeping it between 140 and 150 millimeter of mercury, as the American Heart Association guidelines says, to around 140 millimeter of mercury is the best approach. What is effective treatment? So essentially, I think that there has to be some parameter. We can actually write the order, but we also have to make sure the blood pressure actually got reduced. So the blood pressure goal should be achieved within 2 hours of initiating treatment and should be maintained for a period of 24 hours after initiation of treatment. Now, what do we do about mass effect? I think that there is intraventricular hemorrhage, there is hyperosmotic treatment and surgical evacuation to reduce the mass effect that's seen with intracerebral hemorrhage. Now, surgical evacuation has been tested since the 50s with intracerebral hemorrhage. I mean, it made perfect sense that you have on the left-hand side an intracerebral hemorrhage, a lobar intracerebral hemorrhage. You actually have edema around the hemorrhage. You actually have some concentration of lactate. There is also some reduction of cerebral blood flow. Once you actually evacuate the hematoma, there is actually reduction in mass effect and edema. There's also reduction in some of the metabolic profile, the lactate accumulation, and there is also improvement in the perfusion. So in theory, it makes sense for surgical evacuation. But essentially, the recent trials, so first of them actually being the international surgical trial of intracerebral hemorrhage, the STICH trial, actually looked at patients with supratentorial intracerebral hemorrhage within 72 hours and randomized them to surgical evacuation and conservative management. So again, within 72 hours, and then treatment had to be initiated within 24 hours. And the rate of favorable outcome at 6 months was very comparable. So despite surgical evacuation, the rate of favorable outcome was 26% compared to 24%, not a significant difference.
So essentially, we didn't really see a benefit of surgical evacuation despite all the theoretical benefits one can see and postulate. So there was actually insufficient evidence that a general policy of urgent operative intervention in patients with supratentorial intracerebral hemorrhage. There was some evidence that superficial hemorrhages, lobar hemorrhage, may actually benefit. So perhaps the deep hemorrhages like the ones located in basal ganglia and thalamus may not benefit. The ones that are actually cortical and lobar may actually benefit. So STICH II trial was done, and this time actually just looking at patients who have lobar intracerebral hemorrhages and taking the 601 patients to randomizing them to surgical evacuation and conservative management. And if you look at the favorable outcome at 6 months, 41% in the surgical evacuation arm, 38% in the conservative medical arm. And again, no significant benefit between surgical evacuation, even for lobar intracerebral hemorrhages, as compared to medical treatment. And that actually made people think that perhaps open surgical evacuation may not be the best way for treating intracerebral hemorrhage. Obviously, when you're doing open surgical evacuation, there is neural injury during retraction and dissection to approach the clot. Sometimes the clot is incomplete removal. And as soon as you remove, sometimes there is rebleeding because you took away the tamponade effect by decompression. And perhaps if we wait too long, the secondary injury is already initiated. So removing the hematoma does not prevent the cascade of secondary injury in the tissue around the hematoma and perhaps distant to the hematoma. So now more minimally invasive strategies are being investigated. So here actually, in open surgical evacuation, I actually showed you some of the results. So in an ideal world, you can see the hemorrhage that's deep. So this is a basal ganglionic hemorrhage. And you can see while the hematoma actually has been evacuated, there is actually evidence of hypodensity around the surgical tract. So there is actually tissue to the overlying tissue, or there is actually damage to the overlying tissue while approaching the hematoma. And again, the scan on the left hand or the right hand side also shows you something strange, that once you actually evacuate the hematoma, there is actually post-operative bleeding into the hematoma bed and recurrence of the hematoma because of loss of the tamponade effect. So there are consequences that are not desirable of open craniotomy. So people have been talking about minimally invasive approaches. For example, here you can see a basal ganglionic hemorrhage and a small catheter is placed into the bed of the hemorrhage. Hemato is actually aspirated through the small catheter and repeated doses of thrombolytics are administered into the bed of the hematoma and sequentially aspirated. And here you can see 3 days after multiple aspirations and 6 local infusion of urokinase, there is actually reduction and actually almost complete resolution of the hematoma without the large craniotomies that were done earlier. So there is actually new interest in minimally invasive evacuation facilitated by intracerebral injection of thrombolytics. So there was actually a large trial that actually looked at patients with supratentorial hemorrhage who came within 24 hours of symptom onset and randomized them to treatment within 72 hours of diagnosis of a supratentorial intracerebral hemorrhage. And essentially, patients got intracerebral tissue plasminogen activator, 1 milligram 9 times, and also repeated aspiration. And the other group obviously got just conservative management. And there was some trend. 45% of the patients had favorable outcome at 12 months as compared to 41% in the conservative arm. It was not statistically significant. However, it was significant enough that there is actually another trial going on looking at the same patient population, but perhaps trying the treatment in a more effective manner to see if a benefit on outcome can be demonstrated. So I think the future is actually more of minimally invasive evacuation of intracerebral hemorrhage facilitated by local installation of thrombolytics. Now, what about intraventricular hemorrhage? Even when in the 1930s, when pathological series were available, it was clear that the patients who died with intracerebral hemorrhage had blood in their ventricles. So there was something about blood in the ventricle that increased the rate of death and disability in patients with intracerebral hemorrhage. Obviously, there is obstructive hydrocephalus because of the blood. so the cerebrospinal fluid and the blood is dilating the ventricles, there is actually edema, as you can see, around the ventricles. There's also global cerebral edema. So if you look at the brain around the ventricles, you can see a large amount of edema around the brain. And there is also evidence of inflammation in the ventricles. And if you look at clinical series, it is consistent that anybody or patients who have intraventricular hemorrhage have higher mortality as compared to those who do not have intraventricular hemorrhage. So there is clearly a relationship between death and disability and blood in the ventricles. So people have been talking about that all of these patients get an intraventricular catheter. Why don't we use the intraventricular catheter to actually inject thrombolytics to dissolve the clot and remove it from the ventricles, so actually reduce all of the adverse consequences of blood in the ventricles. And it takes around 11 days before the blood will resolve from the ventricles if you don't do anything. If you give repeated doses of thrombolytics, the blood can be resolved within 3 days. Now, it is actually quite different from actually giving intra-arterial thrombolytics, which we have been using for acute ischemic stroke for the last 30 years. The dose is much lower. So instead of 15 to 20 milligrams that we use intra-arterially, we have to use 1 milligram. The half-life is much longer. So instead of the 3 to 5 minutes intra-arterial, the half-life is more into 8 to 10 hours. And there has been some initial trial that actually showed that giving intraventricular thrombolytic actually led to resolution of intraventricular heart faster. And surprisingly, rebleeding rate was very low, which was something initially very concerning, but it seemed like the rate of rebleeding is very low when you give thrombolytics for intraventricular hemorrhage. And here you can actually see a 3-dimensional reconstruction of blood in the ventricle. You can see a catheter is placed into the clot in the ventricle, the intraventricular catheter. And then thrombolytics are being administered. And you can see there is gradual resolution of the hematoma with repeated doses of thrombolytics till it's completely resolved. So multiple doses of thrombolytics and aspiration through the intraventricular catheter can lead to resolution of intraventricular hemorrhage. But the question is, does it actually improve the outcome of patients with intraventricular hemorrhage? So the Clot Lysis, the CLEAR-3 trial actually evaluated that question. It looked at patients who had large amount of blood in the ventricles within 24 hours of symptom onset and randomized them. So everybody got intraventricular catheter, that is standard of care. And then the group that was randomized to TPA got repeated doses of thrombolytics and aspiration. And the group that was randomized to placebo actually got just 0.9% sodium chloride instilled through the intraventricular catheter and aspiration. And if you look at the favorable outcome at 6 months, 48% in the group that intraventricular thrombolytics and 45% in the group that got intraventricular normal saline. So while there is no significant difference between the two groups, the natural history of both groups is pretty good. So I think it does actually appropriate that the standardization of clinical management in clinical trials actually does improve the outcome of patients, regardless of the treatment group that actually they're allocated to. Now, if you actually look at mortality, so death within 6 months, there is a significant difference. 18% of the patients that got intraventricular thrombolytics died as compared to 29%. So it does actually increase survival. But it also actually raises this important question that perhaps not all survival with intervention and stroke is meaningful survival. So I think that we have to be cautious when we actually just improve survival. We have to make sure that it's translating into meaningful survival for the patient and their families. The last thing I briefly want to talk about is effective treatment. How do we actually have a treatment that improves the outcome of patients with intracerebral hemorrhage? And it's pretty clear that one treatment is not going to do it. There are multiple facets to the treatment of patients with intracerebral hemorrhage. And all of those facets have to be optimized if we're going to improve the outcome of patients. So if you look at all the literature, there are 18 facets of care in patients with intracerebral hemorrhage that actually have a direct relationship with death and disability in these patients. And then we were able to identify 26 quality indicators. So an algorithm that evaluates best available evidence or use of best available evidence in a semi-quantitative manner. So these are all the facets. So again, I want to emphasize that one treatment is not going to change the outcome of patient with intracerebral hemorrhage. And in fact, many things that we actually consider minuscule and do not pay attention have a significant contribution to the outcome of patient with intracerebral hemorrhage. So whether it's blood pressure treatment, whether it's treatment of intracranial pressure, whether it's actually for airway protection, whether it's control of hyperpyrexia, prevention of gastric ulcers, prevention of pneumonias, deep venous thrombosis prophylaxis, prophylaxis for seizures, nutrition, making sure the nutritional demands are met, hyperglycemia is treated, if patient actually is anticoagulant, rapid reversal of the anticoagulant effect. All of this actually contributes to the outcome. So we have to optimize all these parameters if we're going to improve the outcome of patient with intracerebral hemorrhage. So we actually looked at a cohort of patients and looked at the management of these patients. So essentially, it's a semi-quantitative scale. So if you actually perform high on all of these facets, so you do the best possible management for all of these facets, you get a score of 26, which is a high performance scale. If you do poor on all of them, your scale will go down or the score will go down to 17 or less. So that means that you haven't done well in terms of all the facets of care that we have managed, and it hasn't been the best available evidence. So obviously you can give a scale for each patient depending on the adequacy or effectiveness of management. But the question is, does it actually predict outcome? And surprisingly, it actually does predict outcome. So if you look at that matrix, and if you perform and get a high score on all these facets in terms of best available evidence and using that to treat the patient survival is much higher than if you are not optimized on all of these parameters. And you can clearly see a difference, a linear relationship, how effective you are optimizing the care in various facets and how it translates into survival for patient with intracerebral hemorrhage. So I think it's important before we leave that we must understand that the treatment of intracerebral hemorrhage is not unifaceted. One intervention is not going to make a big difference on the outcome of patient with intracerebral hemorrhage. Several facets of care would have to be optimized if we really want to improve the outcome of patients with intracerebral hemorrhage. So I want to conclude here with the following statement. I think over the last 3 decades, we have recognized that intracerebral hemorrhage is no longer an untreatable form of stroke. Aggressive management can improve the outcome of patients with intracerebral hemorrhage. And I think as we move forward, we must support future clinical trials to ensure that the treatment of intracerebral hemorrhage is evidence-based and impacts favorably upon patient care. Thank you very much.